Hello, my name is Chandler Montgomery, and I'm a fourth year medical student at Vanderbilt School of Medicine. Today I'll be talking about mobility assessment in the hospitalized older adult. In this talk, we will cover the problem of low mobility, the effects of decreased mobility in older adults, barriers to mobility in the hospital, and we'll go over one method of mobility assessment using the Johns Hopkins highest level of mobility scale. Mobility can be defined as the ability to move or be moved freely and easily. Conversely, how will we define immobility? It is often defined during hospitalization as confinement to the bed or the chair. Also, immobility is a critical step in the cascade to dependency often seen in older adults. And the problem is that this is very common. Over 12.5 million older adults were hospitalized in 2002, and this population has only continued to grow. Also, Zisberg et al. Showed that 35% of older hospitalized patients are classified as having moderate or low mobility during their hospitalization. And Brown et al. Found that on average, 83% of the hospital admission was spent in bed. This translates to only 45 minutes out of bed per day, or in other words, patients spending 23 hours in the bed or chair per day. With these numbers, we can categorize most older adults in the hospital as experiencing bed rest, even if they don't have a specific order for bed rest by their physician. So what are the effects of bed rest on older adults? We can see at 10 days a loss of muscle mass and muscle strength in older adults that is more pronounced in the lower extremities and anti-gravity muscles. And also, more muscle is lost in older adults than in younger individuals. There is also a decline in walking ability that is seen within 2 days of bed rest. And this is an important outcome because the ability to ambulate independently is crucial for older adults' functional independence. Other effects of bed rest include delirium, cardiovascular effects such as decrease in cardiac output, stroke volume, and circulating plasma volume, and an increased risk of venous thromboembolism. And finally, there's an increased risk of pressure wounds. Further downstream effects of low mobility include deconditioning, falls, and increased length of hospital stay. And also, 1/3 of older adult patients who are discharged from the hospital experience a new decline in activities of daily living. This, combined with deconditioning, leads to increased rates of post-acute care facility placement, another undesirable outcome for older adults. And finally, adults who have low mobility in the hospital are 34 times more likely to die compared to those who ambulate 2 or more times a day. What about the benefits of increased mobility? Well, in addition to avoiding the previously mentioned negative outcomes, there's also a decreased risk of hospital delirium, constipation, pressure wounds, and DVT, as well as an improvement in anxiety and depressive symptoms. So why are patients not more mobile in the hospital if we know the benefits and risks? Well, essentially, there's a culture of immobility in our hospitals today, and there are many barriers that contribute to this. First, patient symptoms such as fatigue and weakness can discourage them from trying to mobilize. However, these are not alone good enough reasons to explain the low mobility that patients experience. Other important factors include the use of medical tethers, such as urinary catheters, intravenous lines, and telemetry wires, which limit patients' ability to mobilize. Also, fall prevention initiatives are a huge barrier to hospital mobility. In today's hospital age, falls are considered a never event, and this has led to detailed tracking, the use of devices such as bed alarms, and strict policies to reduce the number of falls at all costs. However, in the Vanderbilt Advanced Care for the Elderly unit, most falls that do occur are not classified as falls with harm. This begs the question, how do we balance the potential harms from fall events with the potential harms from patient immobility? Other barriers include a lack of financial or quality incentive for mobility or functional outcomes. This is in contrast to falls, which are a highly tracked quality metric. And finally, there's lack of resources required, such as increased staffing, processes to allow for more mobility, and equipment to help patients mobilize. So what is being done? Unfortunately, most hospitals lack programs promoting patient mobility, and most hospitals do not regularly assess patient mobility in a standardized manner. However, programs that do successfully increase mobility have been associated with increased rates of patients discharged to home versus facility. Recognition of these problems has caused two major organizations to incorporate mobility into their algorithms. The Institute for Healthcare Improvement has included mobility as one of the 4 M's of age-friendly health systems. And in 2018, the American Geriatric Society published a white paper highlighting the importance of mobility assessment in hospitalized older adults. In this paper, they highlighted one mobility assessment tool, which I would like to teach you today, and that's the Johns Hopkins Highest Level of Mobility Scale. This scale, from 1 to 8, quantifies the amount of mobility that a patient actually performs in a given time period. It is based on observation of a patient's mobility, typically by nursing staff or other staff, and it reflects the highest level performance they have achieved since the last documentation. Ideally, it would be performed twice per day. You can see here that it goes from 1 to 8, with 1, the patient lying in bed, 2, patient only experiencing bed activities or dependent transfer, 3 is sitting at the edge of the bed, 4 is moving to the chair or the commode, 5 is standing for at least 1 minute, and then 6 through 8 are different distances of walking performed. Let's use an example. A patient takes 3 steps from the bed to the commode. In this case, the patient would at least be scored as a 4 because they moved to the commode. However, if the patient stood for greater than 1 minute during this transfer, they would be classified as a 5. Let's do some more practice. A patient ambulated to the bathroom with the assistance of a walker and another staff member. This patient will be scored as a 6 because they ambulated less than 25 feet. Also take note that the assistance of a walker and another staff member did not affect scoring. How about this one? The patient is sitting on the edge of the bed. The nurse knows the patient walked around the unit alone with their walker in the early afternoon. In this case, the patient will be scored as an 8, presuming the distance around the unit is greater than 250 feet. Questions that often come up about this scale include, does assistance affect scoring? And the answer is only in the case of a dependent transfer or lift. A dependent transfer or lift would be defined as the use of a lift device or requiring the assistance of 3 or more people. And finally, score is based on the cumulative performance during a session of care. That means the patient can take rest breaks while they're walking or standing, for example. So in summary, we have learned that low mobility in the hospital is common and associated with adverse outcomes. Increased mobility is beneficial to patients, and mobility assessment and documentation is essential for mobility tracking and goal setting. The Johns Hopkins Highest Level of Mobility Scale may be used to assess patient mobility, and it ideally is performed at least twice daily and is used to set a daily goal for patient mobility attainment. In this way, we can document the mobility a patient actually achieves and use this information to help our patients achieve the highest level of mobility possible for them in the hospital. Thank you.